Hello, this is Dr. Lori Gardner, and I will be lecturing on Module 3, Disruptive Impulse and Conduct Disorders in Children and Adolescents. These are the objectives, and I'll let you read those for yourselves. So, impulse control disorders. In disorders of impulsivity, the patient's actions are impulsive and linked to some kind of negative consequences, but the patient lacks control over those consequences and the impulses. Impulses can cause tension on arousal, and the actions cause pleasure, gratification, or a sense of release. So the first thing we'll talk about is trichotillomania, and that is also known as the hair pulling. So the term is used to describe recurrent pulling of one's hair. It's a distressing chronic condition. There's increased tension before the act, and usually there's some type of relief of that tension afterwards. Some things trigger it, like hyperarousal or boredom. Even sitting down watching television can trigger trichotillomania. It's prevalent in about zero point 0.6 to 3.4 of the general population. Girls, more frequent than boys, are affected by trichotillomania. About 10 to 13% of the college age population are affected by this. Onset is in middle childhood or early adolescence, most frequently before the age of 17. Some of the risk factors include having a family member that has obsessive compulsive disorder or even early exposure to trauma. So how do they present? They usually have hair loss from the scalp, the eyebrows, eyelashes, and pubic hair. And it's accompanied by ritual behaviors, sometimes, such as even eating the hair that they've pulled out. So there's non-focused, which occurs in about 75% of adult patients with trichotillomania. And that is they're just not even thinking about what they're doing when they're pulling their hair. It's not something that they're consciously doing. Oh, I'm sorry, I didn't mean to do that. Or focused. There's a conscious effort to reduce the sense of tension that they have. That behavior is often kept secret. So if they are maybe sitting watching TV and they're just randomly pulling out their eyebrows and someone's there with them, that's different. But a lot of times they do this in an environment that they're secluded and there's no one else around. There is embarrassment over the hair loss, so they usually limit their social activities. You'll see little girls with caps on because they don't have hair, so they're hiding their hair. They're not comfortable wearing any wigs or anything like that. These patients normally have a negative body image, and they experience distress over not being able to control the hair pulling. Some of the comorbidities that are seen with children with trichotillomania would be mood disorders, anxiety disorders, substance use disorders. As they become adults, they may have a history of personality disorders. They may have borderline personality disorder or OCD. So there's non-pharmacologic treatment, which would be self-monitoring. So we get them to have a journal to monitor when they're doing this activity. Where are they when they're doing this activity? Was there a trigger that occurred prior to the hair pulling? That's also a part of awareness training. There's stimulus control, stimulus response intervention, or competing response intervention. So you try to find a way, or therapists will find a way to have them do something instead of pulling their hair. biofeedback, desensitization, and habit reversal training, which I will refer to the rest of this lecture as HRT. Some medications that have been proven effective would be escitalopram or Lexapro, or fluvoxamine, which is Luvox. Fluvoxamine, I've heard there's good results with fluvoxamine. More pharmacologic treatment would be venlafaxine, naltrexone, and naltrexone is good for decreasing the habit itself. Some have even used lithium, mood stabilizers. If they're on an SSRI, you can augment that SSRI with risperidone. Sertraline and clomipramine have also been used. Some other medications that you may consider for anxiety of these patients would be buspirone, clonazepam, or even trazodone. Next, we'll move on to skin picking. Skin picking is also called psychogenic excoriation or dermal titillomania, and that's respective picking or scratching or gouging the skin that results in tissue damage or infected lesions. It's habitual, ritualistic, tension reducing, and egocentric. The self views behaviors, thoughts, and attitudes as acceptable and consistent with their personality. So about 2.7 to 4.6 of college students experience skin picking, and about 1.4 to 5.4% of the general population experience skin picking. This is more prevalent in women than men. The age of onset for this is about 15 years old. So a lot of patients who have this skin picking are often unaware that it is treatable. They're usually ashamed and embarrassed by the skin picking and the scars and the infections that they get. There's oftentimes a tension or a nervousness before the skin picking occurs, and they usually have pretty severe skin excoriations, infections or scarring. It's not just a little bit of picking. These patients really cause damage to their skin. Nail biting, and this is not your typical just bite your nails when you're nervous, but these patients tend to bite their nails so bad that their hands are usually always raw, or their fingers there around their nails are infected. Some of the comorbidities of this would be OCD, mood disorders, anxiety disorders. They may have body dysmorphic disorders or BDD. They may have substance abuse, eating disorders, or personality disorders. The treatment, non-pharmacologically, individual HRT or CBT. As far as medications, we try fluoxetine, naltrexone. Again, naltrexone is beneficial for the behaviors, trying to combat those behaviors that they have. Clomipramine and lamotrigine are also useful. So we'll move over to Tourette syndrome. That is a childhood onset neuropsychiatric disorder by motor and vocal tics that persists for longer than a year. It's characterized by multiple motor tics and at least one vocal tic. The tics must occur many times a day for a period of more than a year. And onset must be before the age of 18. So if you're treating someone or someone comes into clinic with Tourette's, that is something that started in childhood. That is not something that someone develops after they become an adult. So there's simple characteristics or simple so they may have simple movements or simple vocal tics. And simple would be a single head movement or movement in a limb that involves only a few muscles, like neck jerking, eye blinking, or facial grimacing. And simple vocal tics include grunting, sniffing, snorting. They may be barking, coughing, or throat clearing. And some of the more complex would be jumping, touching, repeatedly smelling an object, or copropraxia, which is an involuntary, vulgar, or obscene gesturing. If they have complex expression of single words or phrases, changes in pitch or volume. Or they may have coprolalia, which is an involuntary use of obscene words. The prevalence is low, with about 0.5 to 1% of the general population being affected with Tourette's. The onset is before the age of 18 years old. It's hereditary in about 90% of the cases, and this affects males more than it does females. Some of the risk factors of Tourette's include the maternal use of caffeine during pregnancy, use of nicotine and alcohol during pregnancy, possibly neonatal anoxia. Maybe there's delivery by forceps or maternal stress during pregnancy. So the age of onset for Tourette's is between 4 and 6 years old. To meet diagnostic criteria, the onset must occur before the age of 18 years. Remember, you will not be diagnosing an adult with new onset Tourette syndrome. They may have repetitive play behaviors like mental play, echophenomena, touching, or self-injurious behaviors. Some of the comorbidities would be anxiety disorder. Some of these patients tend to have panic disorders, agoraphobia disorders, separation anxiety, or over anxious anxiety. They may also have OCD, ADHD. They may have sleep disturbances like nightmares or aggressive behaviors and explosive tantrums. So how do we treat someone with Tourette's? Well, we can try HRT, or exposure and response prevention, and this is usually done by a therapist. Pharmacologically, we may use beta blockers or some antipsychotics like risperidone. Risperidone is normally given about 2.5 milligrams per day, but can range anywhere from 1 to 6 milligrams. Haloperidol or Haldol is FDA approved, as well as Pimozole, which y'all may not be able to see. It's Pimozole, or ORAC. Both of those are FDA approved for the treatment of for Tourette's. Some non-adrenergic agents may also be used, like clonidine, guanfacine, or Strattera, toxamine, which you had in a previous lecture. So let's move on to conduct disorder, also it's referred to as CO. Children with conduct disorder often ignore the rights of others and display unmanageable behavior, and they have a high risk of developing antisocial behavior later in life. The DSM-5 says about conduct disorder, there's a repetitive and persistent pattern of behavior in which the basic rights of others are violated, as manifested by the presence of at least 3 of the following 15 criteria for the past 12 months, with one of the criteria being present in the past 6 months. So they're going to display at least 3 of these 15, and you guys, there's quite a bit. I don't expect you to memorize all 15 of these, but you should know that they have to have at least 3, and it should be at least one of those within the last 6 months. So aggression towards people and animals, bullying, threatening or intimidating others, physical cruelty to animals, stealing while confronting the victim, forced sexual activity, property destruction. They may use a weapon that could cause serious harm, or they may initiate physical fights. They may deliberately set fires or destroy property. They may be practice deceptiveness or theft. They may lie for personal gain. They could be stealing without confronting the victim, which is shoplifting. Serious rule violators, like they really have no regards for the rules. Or they lie for personal gain. They may break and enter a house, a car, or a building. They may stay out at night before the age of 13. They may run away from home overnight at least twice. And usually truancy begins before they're 13 years old. So you may be sending these children maybe going to school, but not going to school. So they're ditching class. The disturbance in behavior causes clinically significant impairment in the social, academic, or occupational functioning. In patients 18 years or older, the criteria for antisocial personality disorders are not met. So what's the prevalence? There's a lifetime prevalence of about 12%. This affects males more than females, and it is common in late childhood and adolescence. So some of the courses of temporal risk factors include having a low IQ. Family risk factors include parental rejection, neglect, or abuse, or there may be some genetic or environmental factors also. And how can this be prevented? By building a child's self-confidence. So this is something that has to start early once the child is already acting out. You want to build self-confidence for these children. And we'll move on to oppositional defiant disorder, or ODD. That is disruptive behaviors, especially oppositional patterns and aggressive behaviors, are among the most frequent reasons for children and adolescents to be referred to for psychiatric evaluation. And the DSM-5 has divided ODD into three types. There's the angry and irritable mood, there's the argumentative defiant disorder, and there's the vindictiveness. So one thing to note is that early symptoms of being touchy, easily annoyed, resentful, spiteful, and vindictive are often associated with the development of ODD. So according to the DSM-5, for a diagnosis of ODD, it requires a child to have at least 4 symptoms from the following categories. The symptoms must occur for at least 6 months and have a negative impact on social, educational, or occupational functioning. They may have angry, irritable mood, where they often lose their temper, they're often angry or resentful, they're very touchy or easily annoyed. They may be argumentative and defiant, where they often argue with authority figures or adults. They actively defy or refuse to comply with requests from authority figures or with rules. Often deliberately annoy others. They often blame others for his or her mistakes. They may have vindictiveness, and where they've been spiteful or vindictive at least twice within the past 6 months. The prevalence is about 3.3%. This affects males more than females. And ODD precedes development for conduct disorder, especially without a childhood onset. It's episodic, recurrent, impulsive, aggressive outbursts. Some of the comorbidities of ODD include ADHD and conduct disorder. Some of the risk factors of developing ODD include development of anxiety and depressive disorders, emotional dysregulation. They have a very hard time regulating their emotions. Harsh, inconsistent, neglectful child rearing is a risk factor. And they have a risk for bullying their peers and being bullied as well. They may have been born prematurely. They may have had birth complications. They may have been exposed to toxins in utero, such as alcohol, smoking, or drugs. They may have an insecure child-parent relationship or attachment, trouble in the family. They may have poor relationships with their siblings, or they may have very poor parental supervision for whatever reason. There may be sexual abuse. They may have a lack of friends. This is also high risk parenting practices are also a risk factor where the parents are often critical, controlling, harsh, or abusive, or even physically abuse these children. Some of the distinguishing features, they're negative, they're hostile attitude, they're argumentative, they don't want to follow the rules, so they don't. They may blame others. They're defiant toward authority figures, and they have emotional dysregulation. And we've already gone over that slide. Let's talk about intermittent explosive disorder. That's recurrent behavioral outbursts with failure to control aggressive impulses manifested by either a verbal aggression or physical aggression towards property, animals, or other people. And that occurs about twice a week for a period of 3 months. These episodes don't injure anyone or anything. So with intermittent explosive disorder, that's going to go on at least twice a week for 3 months. So that's not something that, it happens once or twice. Parents come in, they're all upset about this. They have to have a persistent pattern. They have three behavioral outbursts involving damage or destruction of property and or physical assault involving physical injury against animals or people within a 12-month period. The magnitude of aggressiveness expressed during a recent outburst is grossly out of proportion to the provocation or to any precipitating psychosocial stressor. So their reaction does not match. Their reaction doesn't match an action. They have recurrent aggressive outbursts. They're not premeditated and are not committed to achieving some tangible objective. There's recurrent aggressive outbursts cause marked distress in the person or impairment in occupational or interpersonal functioning or associated with some kind of financial or legal consequences. A lot of times, some of these people don't even realize how explosive they are, whereas some others may understand and they come and seek help for that. I recently had a patient seeking help for IED. The chronological age is at least 6 years old. Recurrent aggressive outbursts are not better accounted for by another mental disorder. And there's a lifetime prevalence of about 4%, more common in males, common in late childhood or adolescence. It's episodic, recurrent, impulsive, aggressive outbursts. Some of the risk factors include a history of physical or emotional trauma, long-term displacement from home or family members. So some of these children may have been placed in foster care. And there's a high prevalence or risk factor if you have a first degree relative that also has the same. Some of the differentials you may see would be adjustment disorder, social anxiety, intellectual disabilities, ADHD, PTSD. They may have, you may consider depressive or bipolar disorders, antisocial personality disorders, or even disruptive mood dysregulation disorder, which we will go over shortly. The management includes antipsychotics and antidepressants, integrated psychopharmacologic, psychotherapeutic, psychoeducational, and case management. So as I told you, we would go over disruptive mood dysregulation disorder or DMDD. That is chronic, severe, persistent irritability. There's two prominent clinical manifestations for DMDD, I'm sorry. Frequent developmentally inappropriate temper outbursts, verbal or behavioral, occurring on average of 3 or more times per week over at least a year in at least two settings. So like home and school could be the two settings. Severe irritability presenting as chronic, persistently irritable or angry mood between these temper outbursts. So the DSM-5 added DMDD, the DSM-5 TR, I'm sorry, added DMDD to address children who present with chronic irritability, um, relative to children presenting with classic bipolar. Many children were getting diagnosed with bipolar disorder off the scale. And so now we have DMDD because those children most closely relate DMDD versus being diagnosed with putting a label of bipolar on a child early on. The onset of DMDD must be before the age of 10 and should not be applied to children with developmental age younger than 6. The use of diagnosis restricted to age groups where validity is established, so 6 to 18 years old. And these children are at risk for developing unipolar depression and or anxiety in adulthood. Some of the risk factors for DMDD include early trauma, the death of a parent, parental grief, divorce, or malnutrition. Many with DMDD meet criteria for ADHD and anxiety disorder, disrupted family life, psychological abuse or neglect. Some risk factors include limited parent education or possibly a single parent household. Some screening tools that you'll want to know would be the Behavior Assessment System for Children or the BASC-3 and Child Behavior Checklist or CBCL. And that is for these diagnoses that we covered today. Alrighty, and these are my references coming up. If you have any questions regarding this lecture, please let me know.